Hello, everyone. Good evening. It's 7 o'clock from where I'm sitting. It's really lovely to be here. And I'm grateful to the Diabetes Research and Wellness Foundation and the Diabetes Professional Care Group for inviting Charles and myself to present this evening to all of you about diabetes as part of the United Through Diabetes meeting session. Tonight's session between now and 8 o'clock is to talk about diabetes, 15 essential health checks that everyone with diabetes should have. So a little bit about who we are. Me, firstly, I'm Mayank. I'm a diabetes consultant based in Southampton. I've been a consultant about 14, 15 years now, and my role is chiefly in diabetes care, doing clinics, some hospital inpatient diabetes care, and a lot of teaching and training of patients and healthcare professionals and members of the public as well. So it's really nice to be here. Charles, a bit about yourself.
Yeah, so as Mayank said, I'm Charles. I'm a consultant pharmacist in primary care and diabetes. So I've been a consultant pharmacist for 3 years now. I run general clinics within general practice, and I also run diabetes specialist clinic within general practice as well. I've been involved with local Diabetes UK patient groups and supporting them with the management of diabetes and good health promotions. And yes, so it's one of the things I'm quite interested in, supporting people living with diabetes.
Thank you. So without further ado, I hope you've all had a chance to get comfortable. It's cold Wednesday evening, and thanks again for tuning in. So thankfully, Charles and I have not got too many slides, we're pleased to hear, which should allow plenty of time for questions, comments, and discussion as we go along, hopefully. So we'll do our level best to periodically look at the chat and see if any comments or questions come through. Do please ask away, and we'll do what we can to address what your thoughts and comments are. So let's start from the very beginning, obviously. And right, so what we're going to try and talk about this evening. So between Charles and myself, with a bit of help from all of you, hopefully, we'll talk about what health checks are, firstly, and outline what they are and why we feel they're needed. And I'll talk about, in terms of some health checks we feel are recommended for everyone with diabetes, and there are others that are kind of, I say optional, but perhaps more relevant to different people at different points in their life, if at all. But as you'll see what I mean as we go along. Okay, right. So before I do that, actually, so diabetes, it sounds obvious. It doesn't hurt, I guess, to just refresh the definition. Diabetes, a long-term condition characterized by persistent high blood glucose, different types, as you all know, type 1, type 2 are the common ones. And obviously left unchecked, this blood glucose will go high and run high lots of the time. And that's where the problems tend to creep in. Because obviously long-term high glucose is not good for you, is it, Charles?
Not at all, and so it's very, very important as well, because as you said, the amount of glucose is a problem, but also the time spent in that amount is also a problem as well. So that's why we're often talking about the duration of the diabetes, isn't it, as well as the amount of glucose in the blood. Absolutely,
because unfortunately, diabetes by its nature is very different in different people, and the persistent state of high glucose, as Charles just has alluded to, unfortunately can contribute to a premature furring up of very key blood vessels in the body. And that's where some of the horrible, what we call complications of diabetes can happen. And we'll come back to those as we talk through the checks, I'm sure. Okay. So essentially, we're all busy people. It's been a really stressful few months for various reasons, obvious reasons for all of us. And yet diabetes continues. You know, the virus is still there, but diabetes is still there and will be after the virus has gone. Diabetes will still be there. So it's really important. What this pandemic has taught me in hospital, and I'm sure Charles has some thoughts, is about how we can support all of you living with diabetes to perhaps reduce the risk of harm from diabetes to all of you, essentially. And interestingly, not everything that has to be done is very high tech, we're pleased to hear. There's some really close to home solutions to help you keep you healthy that can be done, of which health checks are part of those. So it's always recommended that those living with diabetes have these health checks at least once a year. And despite being busy, working, night shifts, day shifts, we really encourage those with diabetes to go for those health checks, even if they feel fine. It might be that some people say, I feel absolutely fine. You know, the bloke next door's, he's okay, I'm okay, we're all right. We don't need to have these checks, we feel fine. Thank you very much, we're all right. And the challenge of diabetes, as you well know, it can affect different people very differently. That's the cruelty of diabetes, sadly, in that between no two people's diabetes is the same. So we appreciate advocating, selling this to all of you to attend for health checks is a difficult thing to do if you feel well. And we obviously want to encourage you to talk to your healthcare teams about why these checks are important. Any comments on that, Charles?
Yeah, it's just to add as well that just as you've said, it's very, very important to have these checks. And this is the reason why your GP practices are very willing to be flexible around you. So as Marek said, you could be having night shift, day shifts. We do appreciate the fact that you do have a life outside diabetes, and we need to respect that. And the whole aim of general practice is to try and see how we can fit these checks around you, because the checks are opportunities for us to do a touch point to see how you're getting on, to see what else we can do to support you. It's also a screening opportunity, as Marek said, to try and screen for any problems that might not be seen, because you might feel fine, but something might actually be happening under the skin. And I'm sure Maya could talk a lot about that as well.
No, thank you, Charles. Yeah. So again, as you knocked sense already, we're really passionate about this. It's really important all of you consider making the time for whatever it takes, an hour or so, to go and have these checks done that are relevant to you as per your diabetes situation and your local needs, essentially. And what, again, the pandemic has taught me is that, because a lot of you I know have difficulty accessing healthcare, we appreciate that. And we know that in a typical year of 8,760 hours, if somebody is lucky, they may get to spend 2 hours a year with a healthcare professional. So part of this process of health checks is making sure you feel confident to ask the right questions of your healthcare team, the pharmacist, the doctor, the nurse. You spend that time you do have with them very constructively. So do feel empowered, go in informed, and take your questions with you is something we'd urge all of you to do when you go and see your doctor about any particular ailment. If you have diabetes questions, take them with you to a pharmacist, nurse, or doctor. It's really important. Okay. I mean, Charles, is there anything particular you get asked quite a lot by patients, particularly with diabetes?
Yeah, so often they always ask about, why do I have to do this test? And I think often I'm always trying to explain the importance of the test, which I do appreciate, because often you have a recall system within general practice, and a letter goes out or a text goes out, come for this test. And most people don't know why the test is important. So there is a change and a movement within general practice, within the practice nurses and the pharmacists and the healthcare coordinators, to try and break it down a bit to people living with diabetes. This is the reason for the test. And I'm sure as we go through those tests as well on the list, we'll be able to explain more about that. But I think, as you earlier said, one of the things COVID has done for us is that COVID has forced general practice to find new ways of supporting people living with diabetes to look after themselves at home, to self-assess, so that we can actually make decisions based on their self-assessment. So I think we're actually involving the person with diabetes a lot more, because we feel that they deserve to have ownership over their care.
Yeah, absolutely. So this, obviously, you guys out there who have diabetes, live with diabetes 24/7, 365, absolutely. So this is your chance to obviously have those thoughts, the confidence to ask the right questions and seek advice from healthcare teams. And obviously tonight we can't comment on individual GP surgeries and around the country. We appreciate the situation is different, but we hope obviously you're in a position where you can access the means to have your health checks done locally close to where you live. And if not, obviously that's a conversation locally to have nearby to work out what can be done to improve things, because diabetes by its nature is a serious disease, and that's not me being flippant or cheeky. I still see people in 2021 who say to me, I've got a touch of the sugars, I've got mild diabetes. And I'm not here to scare anybody, of course not, nor Charles, but it's a serious disease. And the whole business of these health checks, that we will get to, I promise, in a minute, is to really make sure everyone understands, by finding things early, you can reduce massive risk of harm down the line. Okay, so please be mindful how serious a disease diabetes is. So let's move on. Excuse me. The first slide. Okay, so the opening slide talked about 15 or so health checks. Of these, 8 of them, give or take, are what we call the so-called physical checks. So I've just done it on over a couple of slides with Charles. The first slide here talks about a few things. Let's just take a bit of time going through each of these. So the first check we recommend people have done is an HbA1c. So Charles, how do you explain HbA1c to a patient? What do you say it is? So
again, when we explain HbA1c, it's quite a very complex thing to explain to people living with diabetes. So we're sort of trying to break it down a bit to say that basically, when we do your HbA1c test, it gives us a retrospective figure to tell us what your sugars in your blood have looked like in the last 90 to 120 days. So it's more of an average than anything else. So it's giving us an average of that long period of time, the previous 90 to 20 days of sugar in your blood.
Sure, thank you. So what it can't do, as Charles has alluded to, it gives us no idea on the everyday ups and downs of your sugar levels. That's what finger pricking is for. Think of think of HbA1c as a photograph of 3 months, and think of finger pricking as a video DVD recording, if you like, or a stream, whatever you want to call it. But this is a one snapshot blood test, and it's useful because it paints a bit of a picture for your diabetes life over the last 3 months. And we know that there are reasons when it can be high or low. So Charles, what levels should patients be looking for their HbA1c? How do you measure where it should be at, for example? What informs you?
So again, the different things we look at. So we try to individualize your HbA1c target. So again, to based on what you want to achieve, but we do have figures in our minds that we feel are good figures depending on what your conditions are. So depending on your age, depending on how other comorbidities that you might have, depending on how confident you are in achieving a target, we will decide what numbers we'll be going for you. So again, we'll probably go for numbers closer to normal as possible. So we'll go for different units. Again, the units are different depending on your practice, depending on your clinician who you speak to. We have 2 different units, one referred to as millimoles per mole and one referred to as percentages. So those numbers are numbers I think will be specific to you, though, discussing your personal clinic with your specialist.
Thank you. So as Charles said, there's 2 ways of looking at HbA1c. There's a percentage number, which increasing locally certainly is used much less often now. So more commonly, I think it's becoming more common that your HbA1c is referred to in millimoles per mole. And a figure that's bandied around quite a lot that Charles, I think, touched on, that the sort of place to sort of safety, if you like, is between 48 and 58 as a reasonable place to aim for. Not for everybody, because for some people, being close to 48 might push their sugars too low on a day-to-day basis, and we don't want that. But equally, drifting above 58 longer term can increase your risk of harm as well. But that is those numbers can move in various situations, as Charles mentioned. So if you're an older person, if you've got other medical conditions you live with, there are situations and evidence where running your sugars too tight can be more harmful than beneficial. So it's a judgment call between you and your healthcare team to decide what range, broadly speaking, is a safe place for you to be. So be aware of HbA1c. And Charles, what's the difference between HbA1c, Charles, and fasting glucose? Is it timings? Does it matter with this blood test or anything?
So yeah, so for HbA1c, it doesn't matter what the timing is. So you can have the test whenever you want to have the test, any time of the day. Obviously, if you're having a fasting test, which we hardly do these days in general practice, you will need to be able to fast for at least 10 hours, 8 to 10 hours. But again, we rarely do a fasting test in general practice now. It's just simply a HbA1c test. More convenient.
So to clarify, the need for doing a fasting blood glucose if someone's known to have diabetes is pretty much not needed anymore, really. And if you're suspecting someone's got a new case of diabetes, this might be a blood test you're asked to have done called HbA1c, as we said. It's a non-fasting test, haven't done any time, and that's the beauty of it. It's random. It can be done anytime across 24 hours. It's fine. But you can't use it, for those who are interested, you cannot use this test to diagnose type 1 diabetes, because as Charles mentioned, this number reflects the previous 90 days sugar levels. So if somebody develops type 1 diabetes very quickly over a few weeks, there might not be enough time for the HbA1c level to rise, and that's why you must never diagnose type 1 diabetes if someone's got an HbA1c that is normal, or even exclude it. If someone's HbA1c is normal, you can't say, oh, you haven't got type 1 diabetes, your HbA1c is normal. That's incorrect, but that's a discussion for a different day. For tonight, think of HbA1c as a means of sense checking how you're doing every 3 months or so. And certainly locally, Charles, we recommend for a newly diagnosed patient, it's checked every 3 months for the first year, so 9 months to a year or so, to see how they're getting on. So
that's a general rule, because it all depends on how stable you are. So like you rightly said, the targets would be between 48 to 58. So when you're first diagnosed, you're being managed on medications or lifestyle, then ideally we'll want to review it every 3 months to see how you're getting on, how the improvements are changing, and then based on that, we can actually expand those intervals to probably 6 months.
Thank you. Yeah, so essentially, when someone's first diagnosed, ideally, we're going to keep very close tabs on that HbA1c number every 3 months within the first year or so, give or take. It's going to vary a bit. And obviously, if you change drug medications, if you change doses, it's good to do it every 3 months as well, because obviously what you don't want to do is just change a drug or a dose and wait 12 months. That's way too long to see if things have worked or not. You will know within 3 to 6 months of a repeat HbA1c after some sort of treatment change if it's been helpful or not. So that's why 3 to 6 months as an initial window is reasonable. So do push for that locally if you have concerns of your HbA1c being too high or equally too low. So, you know, like I said, as we're saying with Charles, you know, either extreme can present risk. So be aware of that.
And if I just add to that, I think
Yeah.
one key thing to be aware of is that it's retrospective. So I think that's the key word, is retrospective. So it doesn't tell you what's going to happen tomorrow. It only tells you what's happened before. So even when you get those numbers, you need to take that into context of what has happened the last 3 months. And another thing that we probably haven't mentioned is that your last 30 days makes a bigger impact on your HbA1c than your whole 3 months. So your last 30 days has an influence on about 50% of your HbA1c reading. So again, once you get those readings and they're good readings, that's fine. But always remember it's retrospective, and there's still things that we need to do going forward to maintain that change.
So and also think about that, Charles, you're right. So essentially, even if somebody, for example, has an illness or a severe infection or an operation or another big medical issue that can cause a lot of body stress, that can cause sugar levels to rise a lot for a few days while they're poorly, for example, and that can declare itself in the HbA1c, as Charles has just said. So if it does come back unexpectedly high, do think about the previous month or two and think, oh yeah, I was really laid up in bed, I was sick for 2 months, and that's why my numbers might have been deranged. So do think about it in those terms as well. Charles, what do you say about blood pressure?
So blood pressure is an interesting one because it's one of the ones that have been massively impacted by the COVID lockdown. Because obviously it's one of the ones you actually have to do physically with the person living with diabetes. A lot of people often don't understand the reason why we do a blood pressure check, because they often don't see any symptoms. And it's trying to spend that time trying to explain to them why the blood pressure targets are important and how that's varied in itself. I think over time, things have changed in terms of how we manage blood pressure within general practice, trying to encourage more home blood pressure monitoring, trying to get more aggregate readings so we can have an average rather than spot check blood pressures. So it is a very, very important parameter to actually assess with people with diabetes, because it does have a big link with all the complications of diabetes, especially the heart-related ones, as we'll go on to talk about.
So essentially, thanks, Charles. So essentially, as I was saying earlier, unfortunately, persistent high blood glucose can contribute to a premature furring up of key blood vessels, and then blood vessels then get stiff, and that can raise blood pressure, which in turn can increase the risk of cardiac problems, as Charles just mentioned. So you can see when it comes to diabetes, it's not just about blood glucose, it's about good blood vessel health, which includes glucose, includes blood pressure and cholesterol, which we'll discuss in a minute. But from a blood pressure point of view, Charles, what can people do to reduce their blood pressure apart from take tablets, Charles? Anything else?
So there's a lot of things you can do. So again, blood pressure does have a link with ethnicity as well. So if you do come from an African background where there is an increased risk of retaining sodium in your blood, it's very important you're mindful of the salt intake you have in your meals. Everyone should be mindful of the salt intake. You should try and restrict your salt intake to the recommended guidelines, which is less than 6,000 per day in your diet, reducing that. But ideally, you need to be mindful of it when you're cooking, how much salt you put in your meals, how active you are as well, physically as well. So trying to improve your physical activity as well, which improves what we refer to as your cardiorespiratory fitness. So how effective your heart is, which sort of maintains that pumping ability of your heart, which has an impact on your blood pressure as well. It's also about your diet as well. It's about the weight management, trying to improve your weight as well. You know, as you can imagine, there is a relationship between your heart and your kidneys. As your blood pressure goes up, it puts pressure on your kidneys as well, and also put pressure on your heart. And that relationship in itself is something we often refer to these days as a heart and kidney problem that's often interlinked. So it's very, very important that we're improving our physical activity, reducing the amount of salt we're having in our diet, trying to aim to lose the weight, and trying to improve that cardiorespiratory fitness.
Sure, thanks, Charles. So we don't all have to be Olympic athletes, don't, in case anybody's worried. It's just about doing your best to reduce your salt a little bit, as Charles was alluding to, because every little bit helps, of course it does. And critically, as Charles mentioned, persistent high blood pressure puts the heart at risk and the kidneys at risk. We'll come to kidneys in a minute, but they're two critical organs that we all need, among everything else, to be working efficiently to keep us happy and healthy from a cardiac point of view, to reduce our risk of long-term cardiac problems. So salt is one intervention. Being active, as Charles mentioned, does help. It doesn't mean joining the gym. We're not asking you to go and don lycra, don't worry, or become mammals in lycra and cycle. Anything people can do to be more active really helps. So for example, locally, I'm forever telling people to use their phone and do a step count, check they can hit 10,000 steps. Not very high tech, not necessarily very scientific, I'll agree. It's just a measure of activity. That's all we're interested in. And for you personally, with your mobile phone, your Fitbit, whatever, you can get a sense of how much activity have I done, because hitting 10,000 steps is a really good marker of a good level of activity to get to across your day.
Yeah.
Sorry.
No, I was just gonna say, yeah, I totally agree with you. I think the move is to keep people moving. So as long as you're moving locally, we often say things like using whatever you have at home, even your stairs. You know, I often tell people that I see in my clinic, you can go up your stairs 3 times a day. You can go up 10 up, 10 down. You can increase the pace every week. And that in itself, during the lockdown, is enough physical activity for yourself. Whatever you need to do that just keeps you moving and keeps your heart pumping is more than enough.
Thank you. Yeah, absolutely mindful that lockdown was hard for lots of us, and the current few months are horrible and dark now, obviously. So being active indoors can be done, as Charles just mentioned. Use your stairs if you've got stairs at home. Use your back gardens. Use your chairs as fitness equipment. Do some squats on the chair. There's stuff we can all do to keep active indoors as well as outdoors. Don't feel too constrained by being stuck inside when it's dark. So activity is important, as is reducing salt. How about alcohol, Charles? Not offering, just asking. Any thoughts on alcohol and blood pressure?
Yeah, so there is a relationship between alcohol and blood pressure. The funny thing about alcohol and blood pressure is that depending on which data you look at, there is either a positive effect or negative effect, depending on which kind of alcohol you take, the volume of alcohol you take, and so on and so forth. But again, the recommendation will always be to stay within the national recommendation, which is about 14 units across the week. And often in my clinic, and often in my clinic, I get people saying, "Oh, but I drink over the weekend." The recommendations across the week, because the best way to think about it is that you're taking the whole week's job and you're giving it to the liver and the kidney to do it in 2 days. So you're putting them under more pressure in a short period of time, even though you think you're drinking the recommendation for the week. So it's spreading it all out throughout the week.
Yeah. So it's a marathon, not a sprint. We're not encouraging you to drink heavily. Don't feel you've got to hit 14 units. We're not offended if you don't, but just be careful is our ask of all of you. I know it's Christmas is coming. It's easily done. And I'm not saying I'm not being a killjoy, but just as Charles said, and everyone says, drink responsibly, I guess is what I'm trying to advocate. And the last thing for blood pressure to mention specifically is caffeine. So again, there's coffee shops everywhere, and we're all now going out a bit more, as you know. So caffeine, any thoughts on caffeine, Charles, in the context of blood pressure?
Yeah, so caffeine is a stimulant, and it does a couple of things. Because it's a stimulant, it can increase your blood pressure. It also can increase your diuresis, so it makes you pee a bit more, which can make you dehydrated as well. So we do recommend decaf where possible, limiting the amount of caffeine intake that you have, and that should help with your blood pressure, and obviously making sure you're staying hydrated.
Yeah, thank you, Charles. Yeah, so caffeine, alcohol, salt are some of the big headline hitters to think about when it comes to blood pressure. So the immediate response from all of you should not just be popping pills for blood pressure. That's part of it, of course it is. But equally, not just think that's the first thing you do. There's always everyday stuff you can do. Are there any particular blood pressure pills in diabetes, Charles, that are best than others for blood pressure, as far as you know?
I wouldn't say best than others. Obviously, we have different pills that work in different people differently, and we have different pills to use depending on the condition you have. So with people with diabetes, we'll often go to a class of drug first, depending on if you have kidney problems, depending on your ethnicity, and so on. So I would say it's probably best to speak to your healthcare professional about it first, and they'll look at the different parameters about your care and make that decision. But we do have well-defined guidelines for supporting people that have high blood pressure and diabetes, which is slightly different from people who have just high blood pressure.
Sure. So commonly used ones, examples include ending the word april, so ramipril, enalapril are used quite commonly as far as I'm aware, and sartans as well, so losartan, candesartan, there are others, but there are a couple of examples that we do use occasionally. So back to the next on the list. So again, another check we can do to reduce your risk of harm down the line is by measuring your blood cholesterol, your blood fat levels. And again, these are a really important way of thing to look for, because they can contribute to premature occlusion of those blood vessels I keep mentioning, which again can translate to increased cardiovascular risk. And high cholesterol and high blood pressure and high glucose collectively are known to be associated with increased risk of heart attacks, strokes, and lower limb circulation problems chiefly. So that's why it's important to measure those. Cholesterol measurements, Charles, when do you recommend doing them? Time of day, any issues?
So again, we don't worry too much about time of day, because we know we need to be quite flexible with people living with diabetes, because as I said, we do know you have a life and we try to fit it around you. So a random random cholesterol test is more than enough. If there is an issue, your GP will request a fasting test. So don't be worried about fasting initially. We just need to have a general number, and based on that number, we could decide if we need a fasting test or not.
Sure. And I guess the beauty of the blood test, Charles, you can get cholesterol, HbA1c, and kidney function in one blood test, 3 tests.
Exactly. And that's the aim. So the aim is to try and reduce the amount of time the person living with diabetes needs to visit the GP practice or have a blood test, trying to do it all in one, and then we can work our way through the results as they come in.
Sure, thank you. Okay, so last on this list is retinal eye screening. So what that means in sort of simpler speak, essentially, obviously for all of us, our eyesight is fairly key to us to function well in the modern world. And a way of ensuring our vision is okay is attending for regular eye screening. Now, different parts of the country do this in different ways. In some places, you're invited to go for a screening session where you go in the back of a van with a special camera, or in some places you're invited to a sort of special clinic in a GP surgery or a special room with a camera in it. Either way, the idea is your pictures get taken to look at the back of your eyes in more detail. And that's really important because you can pick up spots and changes there that may not immediately impact on your everyday vision, but by ignoring these things now, you'll be storing up problems for the future, I guess. Any experience of that, Charles, from where you are?
Yeah, I think it's not to scare anyone, and we do try not to scare anyone. But we do know diabetes is one of the leading cause of blindness, and it's very, very important that the eye check is done regularly. There has been some changes recently because of the COVID lockdown, and they've sort of been a different way of prioritizing who does their eye test first. But ideally, if you've not heard from anyone in the last 12 to 18 months, then speak to your GP practice, because then they can sort of direct you to wherever your eye screening service is. But it's very, very important, we can't stress it anymore, that you do have your annual eye check, because that's one of the ways we identify problems before they become an issue for yourself.
Sure, thank you. Okay, let's move on. So the rest of these 8 checks, so a few more to look about. So as the picture illustrates, a critical one is foot checks and circulation. So as I touched on earlier, diabetes by its nature can contribute to premature occlusion of key blood vessels. So if the blood vessels supply to your lower legs, to your feet, is compromised, you risk poor circulation. And the first tell of that could be feeling your feet are cold all the time, is one particular tell that commonly people report. Another feeling is that because your feet themselves contain lots of very small blood vessels, they can also get damaged by diabetes. And it's going smaller still, your feet contain lots of nerves which help you feel things. The nerves themselves also need a blood supply. So if the blood supply to those nerves is damaged, the nerves won't work properly, and people risk losing sensation on the soles of their feet. If you can't feel you're stepping on, and you've got visual problems or not got visual problems, you can imagine a situation where you step on something sharp and a problem and it gets cut or infected, and potentially that can be a disaster in diabetes. So I'm forever telling patients, the only place for bare feet is probably in the bedroom or the bathroom, I would say. I mean, any thoughts on that, Charles?
Yeah, no, I totally agree with you. And I'll go a bit further. There's also bad shoes as well. So you could be wearing bad shoes, and if you're not checking your feet regularly, your shoes could be having an impact on your toes, because you can't actually feel them properly. So it's very, very important that we're checking the skin around our feet, skin around our legs, and as well having that check so we can check for the pressures in the feet, check for the nerves to make sure if they're working properly, and just making sure if you have any wounds or things that are not healing properly, or any changes, you're reporting it. And obviously, as Marika said, most importantly, never walk barefooted, because it's very, very important that you're actually wearing good shoes, shoes that don't compress on your toes, and shoes that allow your feet breathe.
Yeah. So in terms of what you can do to protect your feet, is all the stuff Charles has just said. So good footwear, not being bare feet, good hygiene for your feet, of course, that sort of thing. And the reason you go for a foot check is because in the surgery, or wherever you choose to go, the nurse, the pharmacist, or the GP, they look at your feet, and the things they're looking for are any obvious deformity and change in shape, change in color, and any obvious change in temperature, because they're really critical tells that something new is potentially brewing. So if you spot those things yourself, please do voice them to your surgery as soon as possible. And your surgery, they may also use a plastic filament, it's called, and they'll apply 10 grams of pressure at various parts of your toes and the soles, looking for evidence of numbness. Because if there are spots of numbness, they can be the first tells there's nerve damage due to diabetes, unfortunately. But building on that, it's important in diabetes not to think every funny symptoms you experience is due to diabetes. So I can tell you, and so Charles can, that there are other causes of numbness in your feet, for example. So we shouldn't just presume it's always diabetes. So I can tell you, for example, if you are short of vitamin B12 in your diet or for other reasons, that can also cause nerve problems and reduce sensation. So it's important we think about non-diabetes causes of lost sensation, for example, as one example of something else not always caused by diabetes.
Okay. And just to add to that, again, for those that are taking the medication, like for those with type 2 diabetes, they're taking a medication like metformin. If you've had that medication for at least 3 years or above, it's a good time to have a conversation with your pharmacist, your nurse, or your GP to check for that vitamin B12, especially if you're having those food problems, because those are what is usual side effect that we might see with it. So Mayaga said it might not be the diabetes, it might actually be from the medication we've given you. So have that conversation as well.
So Charles, how can metformin cause B12 problems? What's the link?
So based on the way metformin works and based on the research that has been done, metformin can actually reduce your level of vitamin B12. So we usually recommend that after 3 years of being on regular metformin, that you probably check for your vitamin B12 levels to see if it's stable or low, especially if you're complaining of lower link problems.
Okay, and I guess linked to that, because you need vitamin B12 to also make blood cells properly, if you're found to be anemic and you're on metformin tablets, it's worth checking your B12 to make sure that's not the cause of your anemia as well. So it's an important thing to think about. But probably a broad balanced diet should reduce the chance of B12 deficiency. But as Charles said, if there's other mitigating factors, do get it explored and checked out, is what we'd suggest.
Yeah.
If you're found to have foot ulcers and your doctor recommends a podiatry review, please do attend for that. Because the podiatrists I work with locally, I'm sure Charles does, are absolute legends. They can do amazing stuff to reduce the impact of ulceration and damage to people's feet. And again, for me, like eyesight, my feet are really precious to me, as I'm sure they are for all of you, because without those, you can't mobilize, you can't do things. So they're a good, important enabler of physical health, of course. So doing all you can to protect your feet is important. And you may be shocked to hear that if somebody gets an ulcer, the average time for an ulcer to heal can be up to about a year or so, which is shocking. But the reason why that is because I hear from my podiatrist colleagues, as I'm sure Charles does, is that when someone's told you've got a nasty foot ulcer, I'm afraid you need to rest up for some time, because the more you put weight on a damaged ulcer, it will take longer to heal. And for every 10 minutes you spend mobilizing on a foot ulcer or a damaged foot when you shouldn't, you undo 23 hours of healing time. 10 minutes, 23 hours. You can digest that. Real statistic, quite concerning. So if you develop a foot problem and you're told to rest, do your level best to follow the advice. I mean, I appreciate it's difficult if you have to work and things. Talk to your podiatrist about compromise and safe way forward. Would you agree, Charles?
Yeah, I totally agree. I think the only thing I'll add to this as well is hard skin. If you're having hard skins on your feet or you're having bunions or things like that, make sure you speak to your nurse or your pharmacist or your GP about it, just to make sure there's nothing under that skin that's brewing. So, and they can give you advice on different things that can be used. So for example, we often recommend Flextol cream for dry heels. It's trying to avoid your skin from cracking while avoiding that infection from going in, trying to make sure that wherever hard skin you've created, there's nothing under there that's actually a wound or also forming. So very important that you don't ignore your feet. Your feet is very important to you. So any changes, let us know.
And the reason, thanks, Charles. And the reason why your feet become dry is because if you get nerve damage, you need your nerves to work to help your feet to sweat. If you can't sweat, your feet can't cool down. If they can't cool down, the skin will get dry and cracked. That's why dry feet can be also a suggestion that you've got some nerve damage because your skin can't sweat properly in your feet. So be aware of, look out for dry skin, which is treatable, as Charles has just said, very easily. Okay. Moving on, in the interest of time, another critical check, up the blood pressure for me, is kidney checks. So as we touched on earlier, your kidneys are mission critical, important key organs in your body. They make wee, they make urine, they produce vitamin D, they produce a couple of important hormones. They're involved in blood pressure regulation. They're really important parts of the body to protect, importantly. And the way you can gauge how they're working is through two key ways of doing it, blood and urine. Can you tell us about those, Charles?
Yeah, so again, as I said earlier, this is one of the questions I always get. People are always confused. I've done a blood test for my kidney function. Why do I need to do a urine sample? And it's very, very important that we know what those two tests tell us. So as we earlier said, when you have high blood pressure, you have diabetes, that has an impact on your kidney. Your kidney also gets rid of waste as well. And your kidney does all the things. So what we do first is the blood test. The blood test checks how well your kidney is working. It's more like the function of the kidney, how well for example, the sieve which is what I like to use, actually works in terms of sieving out the problems that you're putting in it. So if you're sieving something through a sieve, you're checking, making sure it's working properly, it's giving you the outcome you want. The urine itself is telling you the structure of the kidney, so the filter within the kidney. Are we having damages occurring there? Are we having bigger holes? Because what that urine tells us is if there's protein in your urine, which we shouldn't be seeing in your urine normally, except there's damage occurring in the structure of your kidney. So together, those two tests give us a better picture of the well-being of your kidney. So doing the blood test to check the function, and then doing a urine test to check the structure, if the structure is damaged in itself.
And also what's important, thanks Charles, is also that you can have a normal kidney blood test or an abnormal urine sample with high proteins, and the opposite, an abnormal kidney blood test but a normal urine sample. So be very careful. That's why, as Charles said, both tests tell us very different things that are really important. And as with the nerves I mentioned, recognize that there are other causes of kidney problems apart from diabetes. So again, we try and keep an open mind and ask ourselves, could it be something else upsetting someone's kidneys? Because sometimes there are other different treatments to consider. But without you attending for the health check, without having your sample and the means to look at the numbers and see how things change over time, it's difficult for us to gauge what level of support you need next, or what the tests you might need, a kidney scan or a kidney doctor review, etc. That's why going for these tests, despite feeling absolutely fine, is really important. And you can often find abnormal kidney urine sample results and blood tests in very well people who weren't aware that there was a problem. The physical tell from you at home, if your wee is very frothy, if your wee is very dark, if your wee is very smelly, these might suggest either you're dehydrated, got a water infection, or something else. So if you're something new you're not used to seeing and your wee's a different color, get it checked out is what I would suggest. Any other kidney comments, Charles?
No, nothing to add to that. I think it's just making sure that you get the test done. I think one of the issues we often have is that most times people come for a test and they don't have a urine sample, or they went away, they were going to give you a urine sample. So I strongly recommend when you've booked your diabetes review with your GP, just ask for a urine bottle so that you can get that on time and bring it to the clinic, or just get a clean bottle sample and then bring one in. We often say, if you can give us the early morning urine sample, great. But whatever urine sample you give us, we will take it, because we'd rather have a urine sample and not have any.
Absolutely.
So wherever urine sample you can bring it. But ideally, we'll prefer the first early morning urine sample.
Perfect. Yeah. So kidney health is really important. So being, as we said earlier, with blood pressure, being well hydrated, not too much alcohol. Your kidneys like gardens. I tell patients, kidneys like gardens, they need watering but not flooding. So being well hydrated is important. Being careful what pills you take. So any medications to be aware of, Charles, to damage the kidneys that patients might not know about.
Yeah, so again, we always have what we call the sick day rule. And it's about being very mindful of certain medications that you might be taking that could have an impact on your kidney if you're not feeling well. So we're using an acronym called SADMAN, so which referred to as an SGLT2 drugs. So drugs like dapagliflozin, empagliflozin, canagliflozin. Then the ACE inhibitors that we talked about, so things like your ramiprils, the prils and the stans, are drugs that you probably need to be mindful of when you're not feeling well. We also refer to drugs that are diuretics as well. So your furosemide, your indapamide, your benzoyl. Those are drugs that make you pee fluid out. Again, you need to be mindful of that. Then things like your metformin as well, and even high dose aspirin as well, are things that we're mindful of when you're feeling unwell and you're not having good urine output, or your urine is getting a bit darker. Then those are drugs you probably want to speak to your clinician about, but considering withholding on to giving proper advice. A very, very important one that people often forget and use quite often are drugs we call NSAIDs, so your pain relief, so your ibuprofen, your naproxen. Those are drugs that also have an impact on your kidney as well, that you can buy from your local pharmacist, which often I presume you will buy when you don't feel well. So be very mindful of that. If you're having poor urine output, or your urine is getting a bit darker, you're not feeling well with yourself, that you avoid this medication and speak to a clinician urgently.
Yeah, thank you, Charles. So essentially, any illness you're experiencing, a strong fever, you're sweating, losing lots of fluid, or very vomiting or diarrhea, any situation that risks you becoming dehydrated, as Charles said, it's sensible to suspend any drugs like water tablets that make you pee. As you can imagine, that's a sensible thing to do. So park those for a while, a few days, and blood pressure lowering medication, because again, your kidney needs a blood supply. If you drop your blood pressure with those pills, and less blood's going into your kidneys, you risk becoming unwell. So if you're in doubt, you're feeling poorly, seek advice promptly, but certainly, as Charles said, definitely stop water pills and the blood pressure pills urgently, and over-the-counter painkillers, always tell the pharmacist, I have diabetes, is this okay? Just to get that level of assurance, because high street pharmacists have got lots of skills, haven't they, Charles, in this area?
Yes, they do, and they can give you advice. And that's why when you're buying those pills, make sure you speak to a pharmacist. I think I'm a bit more concerned with the ones you can buy yourself without having to speak to anyone, the small packs you can buy from Tesco and so on. So always make sure that when you're buying your pills, you have a conversation with your pharmacist, especially if you're not feeling well, especially if you have conditions such as diabetes and high blood pressure. And then they can give you a tailored advice for yourself, because the way those medications will work for you will differ from someone who doesn't have the same condition as you have.
Great, thanks, Charles. And the last one on this slide is about weight check. I mean, talking about weight, that's the meeting in itself for a week we could talk about. So the headline here really from a health check point of view is making sure you check in formally with your surgery and have a weight check periodically. It's ensuring where you can do your level best to keep your weight where it is, or if you feel you're overweight, been told you're overweight, you know you're overweight, try and lose weight appropriately. But the aspiration is not to gain weight, because as we said before, with heart and kidney, being overweight does put increased stress on kidneys and hearts and things. So where we can manage weight effectively, the better. Beyond today's talk, but there are medications for diabetes, as Charles will know also, that can help people lose weight indirectly or directly, obviously, as part of how they work. And that's worth a conversation with your nurse and your doctor and surgeon and pharmacist to see if you're a candidate for that particular therapy. There are some tablet versions of these things, there are injections, it's a personal choice, and obviously a decision for you to make in conjunction with your healthcare professional.
Yeah.
Sorry, Charles.
Yeah, just to add to that, I think another reason for weight check as well that's very important, especially for the elderly, is that we often use your weight to decide how well your kidneys are working. At the moment, we take a blood test, we send off a blood test to see what your kidney function is. It gives us a number, but that number doesn't take into consideration your age. It doesn't take into consideration your weight, when your weight are on the extreme side or when your age is on the extreme side, end as well. So it's very, very important that we get this data to sort of make sure that we're looking after you properly and we're giving the right medication in terms of safety. Another thing as well is that in general practice, again, to vary from practice to practice, we often do a waist circumference as well, in addition to your weight, to sort of give you a balance between what your weight looks like and what your waist circumference looks like, because these two figures do have an impact on how we define your risk. Because we often do a calculation for your heart risk, which we refer to as a Q risk, and we often require your BMI to make those calculations so we can give you a good advice on what your heart risk might look like.
Thank you. So again, weight management is always there, weight management. So it's not one of those things you just do for a week and forget about it. Diabetes, diet, attention to physical activity and weight are things that hopefully go with you for your whole diabetes life, really, and do your best to keep those in check and seek support if you're concerned. All right. So before I go on to the next thing, I'll just look at the chat very briefly, and a couple of things have come in. Something maybe Charles can help with this. How can data be integrated into storytelling practices?
Yeah, I saw that question. I wasn't really sure what the question was implying, but I believe it's more about talking. I presume that the question is more about how we can use the information we have from research into giving people living with diabetes a sense of understanding their disease in a storytelling way. I presume that's what they're referring to. Would that be right?
Possibly. And the second part of the question, I think, is how have governments navigated common pain points associated with procurement in new or novel ways? Again, I'm not quite sure where that sort of, in terms of what the angle is, but I guess for me, all of this refers to the more data we have on patients with diabetes in terms of blood pressure results, HbA1cs, cholesterol levels, that can all be used to inform a narrative, I guess, in terms of what good diabetes care and successful outcomes look like. That's what I take from that. And in terms of government policy, I don't work for the government, I'll be honest. So I just sort of do what I'm advised to do by my commissioning team in order to provide the best diabetes care I can for the patients that I see. So I can't really drill more than that. So apologies if I can't answer that in more detail. A couple more questions I can just see. Was that it, I think? Is that it, Charles? Or
Yeah, there's one that's just come in. It says, if type 1 diabetes is more likely to get other autoimmune conditions, why are these not tested for longitudinally, not just at diagnosis?
Sure, I think you're right. So having type 1 diabetes, autoimmune disease, does increase the risk of other conditions, but no one quite knows what the time point's going to be. So we could spend a lot of time and energy, checking your thyroid, you're looking up for thyroid, B12 deficiency, celiac disease every year, or wait until somebody gets symptoms that suggest that problem is occurring, because it doesn't happen to everybody. So it's one of those things where probably not worth doing it on everybody for the sake of it, But if symptoms suggest something else is not right, then look for it. And then 9 times out of 10, certainly locally, that's our practice, and that's how we often capture things. So as a quick hint, for example, if someone with type 1 diabetes and lots of hypos, the natural response is, oh, you're having hypos, let's reduce the insulin, which might be part of what you need to do. But remember, think laterally, are you having hypos caused by a different condition? So having thyroid disease, having celiac disease can also cause hypos. Having Addison's disease, we don't produce enough stress hormones, can also cause hypos. But I feel there's no value to doing these things because you can. It's important to do these things if the clinical narrative fits the symptoms, fit the possible condition you're concerned about, and then look for it. So I hope that answers that question in that sense.
Yeah, we have another one here about LADA. So there's someone that said they've been recently diagnosed with LADA, which is a latent autoimmune disease in adulthood, and have been on insulin for 5 months, and they're gaining weight, and they're wondering if this is going to continue while they're in this insulin.
Okay. So again, not going to pry into this person's case, but essentially LADA is think about LADA as like a slow burning form of type 1 diabetes. So classically, type 1 diabetes declares itself over the course of 2 or 3 months, classically. But LADA, a slower burning type 1, can be brewing for months and years, believe it or not. And so the person may have been losing weight unexpectedly, having high sugar levels unexpectedly. The GP may have thought this person's got type 2, getting tablets didn't work, and then weight loss continued. And because insulin by its nature is an anabolic hormone, which in English means that apart from lowering sugar levels, insulin also promotes fat and protein storage. If you've been lacking it, you're going to lose weight. Suddenly you're giving it back to you, you're going to find you're going to gain some weight. I mean, what are your thoughts, Charles, on weight gain caused by insulin? Any particular headlines there?
So nothing in particular. We do know that the insulin can make you gain weight. Again, some insulins have different percentage of weight gain, but we do know insulin makes you gain weight. And I think the most important thing out of all of this is to speak to your clinician, because they can give you advice. And as you get your diabetes better control, the amount of insulin you require will also reduce as well. And again, that also avoids the extra weight gain that you get. So I would say it's probably a conversation you want to have one-to-one with your diabetes specialist, and they can give advice on type of insulins and doses of insulins and so on and so forth.
Thank you. So in answer to the question from this person, I think probably what I would say is you're going to gain some weight for a period of time, I suspect, as the insulin gets on board and your body gets a new level of insulin on board. And my hope would be for you that over time, the insulin will start to plateau off and level off the dosing, but obviously, the importance of diet and healthy eating exercise will be part of that process to maintain weight. It's not just insulin alone that informs weight gain, for example. So do keep paying attention to other aspects of your health apart from using insulin. So hopefully the level will plateau off, but time will tell. Everyone's slightly different. I'm very mindful of time, so I was going to whiz the next couple of questions. A dental question about, dental hygiene. Fantastic question. So our dental hygienist has asked, gum disease is common. Why is that not included? So this is a relatively new growing area of knowledge and expertise, I would say. I personally always ask people about their teeth, and I see them all the time. They, why ask me my teeth? My doctor, why are you asking me? You're not a dentist, but you're so right, whoever this is. Absolutely, always ask about dental health and inquire. And I believe also some dentists have said to me, I asked this person to go for a diabetes check based on the appearance of their gums, and it was positive. So it can go both ways, basically. But as a doctor or a healthcare professional, ask about teeth and dental health and diabetes. As a dental practitioner, if you see signs of gum concern, ask yourself, could this person have uncontrolled diabetes or undiagnosed diabetes? And I'd reiterate that, because sometimes hearing it from two sources for a patient can help advocate the importance of getting those things checked out. Okay, I'm mindful of time, so I'll move on if that's okay. We can come back to any questions afterwards. I'll let Charles pick up the thread after. So we've been through the 8 physical checks. The rest of these, the ones I want to call optional based on your situation, essentially. So they're not all optional, so it's a bit of a misnomer. So a flu jab, I personally would advocate everyone with diabetes, everybody has a flu jab. And what are your thoughts, Charles?
Yeah, no, I totally agree. And I'll probably go as far as say even your COVID jab as well, because people with diabetes, obviously, because of the high sugar you have in your bloodstream, it does have an impact on your immune system. So it makes you more susceptible. So having prevention from this condition is very helpful.
Yeah, and also it's recognizing, people always say to me, I'm not in my flu jab ever again. I had it and I felt terrible. But I'll be honest, if you don't have the jab, there's always that risk of getting the real flu, which is 10 times worse. So yes, you might feel rough for a few days. We appreciate that. We all feel a bit rough after a flu jab. But I personally feel, please, just ride it out for a few days with some fluids, keep warm, paracetamol, sensible dosing, as the pharmacist is listening, Charles is listening, and just have it, a quiet few days best you can, and hopefully things will calm down. Other checks are optional, as aligned with weight management for that where it's relevant, advice on diet and nutrition. So again, it might be your surgery, the doctor, the nurse, without being rude, or a pharmacist might not be the expert in diet and nutrition, but I'm sure they'll know somebody who is, or be able to give some reliable, reputable resources on what works and what's appropriate. What I will say briefly tonight is that I'm sure Charles will agree, there is no one diet in diabetes. There's no such thing as diabetic diet. That turn of phrase should have gone a long time ago. It's about different diets that suit the individual. And I know we hear lots about low carbohydrate diet, low calorie diet, the Florida diet, the 5-2 diet, I'm on a diet, whatever you're going to call it, there are lots of them. And we know that they're not going to work for everybody, but most importantly, the right diet for you has got to be realistic, sustainable, and affordable. That's my sort of entry level to diet advice to people. What do you say, Charles?
Yeah, I totally agree. I think when it comes to diet, it can go both ways. If you're on a poor diet, it could cause more harm than good. So it's very, very important that when you think about diet, you're sort of making more individualized, because again, depending on the type of diabetes you have, if you have type 2 diabetes, you have type 1 diabetes, the dietary advice will sort of is designed to suit your condition itself. So there's no one diet, as Marika said, that suits everyone, but it's very important that once you decide to go on a diet plan, that you're having that initial conversation with your diabetes specialist, and then we can tailor it to something that best suits you, that works for you, and would give you the best outcome possible.
Thank you. But thanks, Charles. And as guiding principles, obviously portion size, avoiding snacking regularly across the whole day, fresh produce best you can, occasional treats. As I said earlier, of course you can drink a bit at Christmas, have the occasional sweet treat. Of course you can. No one's saying you can't. We know there's lots of stigma and ignorance around that. We appreciate that. And it's exhausting, and we understand that. But we've got to keep on fighting this exhausting battle of ignorance best we can between all of us. And so it's okay to have sweet treats with diabetes, shock horror, who knew, on occasion. But that's the same advice for anybody, even without diabetes. So that's the sort of mantra to think about.
Yeah, and we give like simple things. So there's an acronym you could often use that I often share with people living with diabetes, and it stands for FAT, F-A-T, and it's about trying to see which area of that acronym you could improve. So the F stands for frequency. So if you're having pizza every day, or you're having takeaway every day, you could consider reducing how often you are having that as a way of managing your diet. The amount as well, as we've talked about, which the A stands for portion sizes, trying to use smaller plates rather than bigger plates, because often people want to finish what's on their plate due to habit or routine. So using smaller plates will be helpful. And then type of meals that you have. So you could go for more of the brown stuff. So more of the brown bread, more of the brown rice, more of the brown pasta, rather than having the white meals, which have produce higher levels of sugar. So again, it's trying to do those simple day-to-day things that are sustainable.
Thank you. And a big one is emotional and psychological support. So essentially, we know the last few months have been very testing, very stressful, mental health-wise, lots of people. And again, we know access to these services is very variable around the whole country. So I'm not here to advocate and make, I can't apologize that I'm sorry if it's not great where you are, but equally, it's important that people learn to talk and openly with people they trust. It doesn't have to be a healthcare professional. Just try and avoid bottling things up if you can, and just have conversations. It does help sometimes. There are various peer groups locally in your area. You might find a group locally. You might find some sort of online that works for you as a resource. But do talk to your surgery, have that relationship with your healthcare team about if you're feeling particularly ground down by diabetes, or in low mood and depression, poor sleep, and appetite's not so good. They're the tells that all is not well in paradise from that point of view. So do talk, I think is what I'm trying to say politely. Don't bottle things up and expect them to always know what's on your mind. To literally open up where you feel comfortable to do so. And part of that, I guess, emotional support is around education. And for me, education is a critical part of diabetes treatment. And a lot of you listening will have been given some education when you were first diagnosed, perhaps. And we know from experience, the education can then sometimes peter out over time. So they're trying to do more and more refresher courses around here, certainly every few years or so, or pop-up education sessions. But as you well know, face-to-face is difficult. There's a big push on digital agenda, but I appreciate, so does Charles, that not everyone can get onto a lot online easily and use a computer. It is difficult, but libraries, there are groups going on. Find out how it works. Your surgery should know what's on offer. Is that right, Charles? Would you say?
Yeah, so your surgery will know what's an offer. Different local areas offer different options. They do offer the virtual options, and now I think most areas are probably trying to find a way of going back to the face-to-face options as well. Because as you rightly said, there is issues with access to IT, language barrier problems as well, cultural difference. There are multiple things to look out for. But it's very important, if you're interested, and that should be a conversation that should be had at every review. Your clinician will find out what the best education opportunity is for you locally.
Thank you. Okay, moving on. Other health checks, yeah. So again, sometimes in diabetes, there'll be a need to involve other specialist diabetes teams. So lots of stuff can be done for diabetes at your GP surgery and pharmacy level, if you like. But sometimes situations arise where a specialist is needed. And sometimes it's only the health check that you have done that might suggest this. So like I said earlier about kidneys, for example, or high cholesterol, if they declare themselves unexpectedly, your doctor might ask a specialist to think, oh, I've got this guy here, this lady with this, kidney function looks like this, or the urine sample showed this, what do I need to do? And that person might say, oh gosh, okay, yeah, no problem, I'll arrange a review of that person's case. So be aware that not everyone with diabetes needs to see a specialist all the time, but that the access should be there for various time points in your life if needed, such as in response to a health check that showed high cholesterol, uncontrolled high blood pressure, for example, very leaky kidneys, those sorts of things. So that access should be there for you should you need it. Smoking cessation, Charles, any thoughts on that in terms of what people could do to
So there's so many services for smoking cessation at the moment. You can also have a word with your local community pharmacist, because some of them still run the smoking cessation services to support you through the process of giving up smoking. But wherever the case is, if it's something you're interested in, have a conversation with your practice. We've got different practices in different localities have different ways of dealing with providing that smoking cessation service.
Thank you. And literally last couple of minutes to go. I'm sorry, I've talked a bit too much. Sorry. So obviously having a baby, you should be under, if you have diabetes or you're pregnant, you must be under specialist service. Absolutely 100%. No more, enough said on that. And again, we're all grown ups here. So sexual dysfunction can happen, problems with erectile dysfunction, other problems can happen in diabetes. So don't be shy. Sensitive conversations can be had around this. If your concern is getting you down, please do take those conversations with your local healthcare team. And if you have a hospital admission, either a planned elective surgery, you're going to a planned operation, or you're unexpectedly hospitalized for any reason, you're entitled to good diabetes care in hospital. So I work in Southampton. We support our patients best we can with diabetes here. We train our other staff, and we know that not everyone will know. Everyone knows about diabetes all the time. So we can't expect my hospital of 4,000 clinical staff to all be diabetes experts, but we do our best locally to ensure they have enough skills to keep you safe and well in your time in hospital, for example. We have resources, guidelines, that sort of thing. But equally, if you feel you guys don't have it, but either way, if you guys have a good hospital experience with diabetes, please do voice that locally and report that. But equally, if things don't go to plan, voice that as well. So if you can share the good news and the bad news, it'll help hospitals improve their services. Otherwise, without knowing, we don't know what works and what doesn't work. And we appreciate different people have different needs. So it's important you guys voice that if you have particular concerns. So for example, more and more hospitals now are letting people do their own insulin injections themselves if they are not muddled or confused or too ill, for example. More hospitals have the carbohydrate content on their menu. So in your hospital bed, choosing your meal, the carb content is there to help you inform your insulin dose, for example, if you adjust your insulin. So those checks are also there. So in the interest of time, I'll leave that there, but there's some questions that Charles and I can hopefully get to as well. So I hope that's painted you guys a bit of a picture in terms of why the health checks matter, what can be offered to you, and what can be done about various things if they get found. Any closing comments on those, Charles, before we go to the questions?
No, I think we've covered everything. The only thing I'll probably mention in terms of the pregnancy one is just be mindful that when you go into the shop to buy your folic acid, if you do have diabetes, the folic acid you're buying over the counter is not the right dose. So you do need to speak to your clinician when you're planning your pregnancy so they can prescribe you the appropriate folic acid doses.
Yeah, thank you, Charles. I should have said, yeah. And ideally, they want your diabetes to be as best it can before you try and have a baby to reduce your chance of pregnancy-related diabetes issues. But high-dose folic acid, as Charles has just said, absolutely critical, yes. If I now look at the questions, I appreciate we jumped around a little bit, apologies. So if I go to one I just spotted, someone's asked about a particular eye condition and what they can have it treated. I'm really sorry, I can't comment on that tonight. all I can say to you is, if the medication you take is unusual, I would just talk to your local team, because I can't obviously give advice on somebody's case. I'm really sorry without knowing more about it. Okay. There's a question about ketones and type 2 diabetes, Charles. Do you need to check someone's ketones for high type 2 diabetes routinely is the question.
So routinely, we don't have to check for ketones, but if you're feeling unwell, feeling breathless, feeling a bit dry, not having high blood sugars above 15, 17, 18, you should be speaking to your clinician anyway. And at that point, they will decide they need to test for your ketone levels, because then they might be deciding it might be something else. So I would say if you're having high blood sugars, the simple answer to that is book a diabetes review with your diabetes specialist, and they would advise you accordingly.
Thank you. And I guess, Charles, not everyone with type 2 diabetes has the means to check their sugar levels anyway. So if you're poorly and you've got type 2, if you're concerned, as Charles said, just get checked out by your surgery or go to A&E if you're that worried, and they can decide if you need ketone testing or not, because high ketones in type 2 diabetes is relatively unusual, I would say. It does happen, but not to a level that we need to give everyone with type 2 diabetes ketone testing kits at home, because there are situations when it is okay to do that or not. But generally speaking, if you've got type 2 diabetes, you're not very well, you're concerned, seek advice, then they can decide, okay, you better come in for a ketone check or whatever, it can be done, okay?
We had a question here about mental health check included in diabetes check. So as we earlier said, the emotional support is out there. And when you go to your review, we should be asking those questions. So if you do have any concerns, speak to your specialist as well about that.
Thank you. Does that cover all the questions, Charles, do you think?
Yeah, I believe it covers all the questions. The only other question here was, what should the normal blood pressure be in someone with diabetes? Again, the reasons for what your number should be at home is a bit different from what it should be when you're in your GP practice. So we aim for 135/85 or less if you're testing it at home. And that's for if you have no other problems. But I guess it's very, very important that you have this conversation with your diabetes specialist, and they will individualize your targets for you based on what they feel is best for your condition and for yourself.
Okay. Last couple of comments I can just see. Someone's asked about pneumonia jab together with flu and COVID, the triple, my word. I had my flu jab and my COVID booster the same day, I'll be honest. Different arms, I felt fine, but I heard people didn't. So probably, I think personally, the triple will be pushing it, I would say. I think have a bit of a gap is what I'd suggest. Someone's asked about a 15-year-old having a jab. I'm really sorry, I don't do children's health. I could not comment on pediatrics. I'm not ducking it. I'm really sorry. I don't feel I can give an informed answer on that. I'm not a children's diabetes doctor. Normal blood pressure, Charles just mentioned. I think Libra monitors. Okay, yeah, in a nutshell, there's tech on the arms to swipe. Yeah, absolutely amazing game-changing technology, diabetes. My view on them is, of course, they're helpful. If you're suspicious the data on the device does not register how you're feeling physically, do a blood sugar check at the same time to make sure the data is correct, and recognize that if you are somebody using the gadget, the numbers you see on occasion can lag behind blood glucose, because this is measuring, the gadget measures skin fluid glucose, not blood glucose. If you are ill or dehydrated, for example, you may find the number is slightly out of kilter with what you'd expect it to be, so do be careful. Okay, and how to treat high sugar at home, last comment from me. Okay, you've got high sugar levels at home, simple things, one of the best things you can do is hydrate. Fluids are really good to get sugar levels down. Ideally, if you can manage, if you're not on water pills, if you can manage somewhere between 1.5 to 2 liters across the day of fluid to your wee as a light color, so you know you're well hydrated, that can do wonders to bring sugar levels down. Obviously, treating your pain with simple pain relief, paracetamol and such like matters, and bowels, believe it or not, your bowels. If you have sluggish bowels or if you're constipated, I'm sorry, we're all grown-ups here, that can also indirectly raise sugar levels. So keeping yourself moving, as it were, and hydrated can do wonders to help bring sugar levels down. And if you're not feeling too ill, gentle moving around the house, gentle pacing and moving, with gentle exercise, if you like, can also indirectly help bring sugar levels down. Last couple, Charles, someone's asked here, numbness and pins and needles, could that be due to diabetes? What are your thoughts, Charles?
Yeah, so as we said earlier, it could be, it couldn't be. It's one of those things that we decide when we do your food check, and it's just checking out what the cause may be.
This is hands, so the hands.
Did you say hands or feet?
Yeah, hands.
Yeah, so again, I can't really comment on that, to be honest. So I don't know if you want to take that one, Mike.
Hands, okay, so as Charles, if it's in the feet, it could be diabetes. Hands, number of different things. You could have carpal tunnel, for example, a trapped nerve or something, for example. So for that sort of thing, If it's happening all the time, if it's non-stop, does it come and go? There are various tells that point towards different causes, I would suggest. So if in doubt, if it's bothersome to this person, get it checked out at your surgery, get them to examine your hands properly, you know, in terms of sensation. Is there an obvious pattern or distribution to that? Because that can point towards a particular nerve, for example, causing the problem. And that's probably about as far as I would take it from that point of view. I think probably we'll call it there. Thank you, Charles, for your assistance. I hope we've given everybody some information to think about and to take away with them to use for their health checks closer to home. I wish you all a good evening and I wish you all the best, and please keep happy and healthy and look after yourselves. Thank you all very much. And
Have a good night.
Charles. Thank you. All right. Bye.
Night.